Hi, my name is Shelby Mead, and I'm going to be discussing my type 2 diabetic patient that I have done a diabetic concept map on. So my patient presented to the hospital. He's an 80-year-old male. He presented to the hospital with cardiac symptoms and was diagnosed as NSTEMI, non-STEMI. So he presented with left-sided chest pain, arm pain, and jaw pain that was radiating. And he has been in the hospital for 6 days. So I chose to do my diabetic concept map on this patient, even though he is a controlled diabetic. He had more of the micro and macro diabetic issues. So out of my two patients, I chose to do him because he just had a lot more information to go with diabetes. So he's been at the hospital he was at the hospital for 6 days. His pathophysiology is, again, type 2 diabetic, so increased insulin resistance, beta cell dysfunction, impaired processes in glucose regulation. He was diagnosed with diabetes type 2 in 2005. So he admitted with the non-STEMI complicated by chronic kidney disease, stage 3, hypertension, diabetes 2. He does have family history of diabetes. His older sister has diabetes type 2 as well. He is fairly moderately physical activity. I put moderate physical activity due to fatigue. So and upon our discussion, he stated that he was a fairly active person, but lately, or obviously with age, he's gotten to where he can only do certain activities for certain periods of time because of fatigue. So he said he was able to do yard work for a couple hours, then would have to take a break. We discussed his eating habits. He says that his wife is the main one who cooks, and she cooks mainly country-styled foods, so a lot of fried foods. He did state that they eat fast food probably 3 times a week. He does state he does have a minimal to moderate amount of vegetable intake and fruits throughout the week, but not daily. He is a former smoker of 1 pack per day for 25 years, so 25 pack year history. He quit smoking in 1995, although he denies any alcohol usage or any drugs. He does see his eye doctor twice a year for prevention, so I put that information in the top box of my concept map. So for his non-related to diabetic, I know this is a diabetic concept map, but non-related to that, for his hospital stay, they did do a right groin angiogram and stent for him. So I figured I'd get that information out of the way because that kind of discussed why he was at the hospital. So aside from that, his A1C is well controlled. It is 7. We want diabetics to be 7 or below. Is very well controlled. So he is very well controlled diabetic. He is not currently on diabetic medication. He did report he used to be on oral medications. He believed it was metformin, but in the hospital he was not getting metformin because that is not a common med we give in the hospital due to diagnostics and procedures. Can't have that with contrast dye. So a lot of patients won't get, even though that they're on metformin at home, when they're in the hospital for the stay, they won't be on metformin, they'll be on insulin. So his glucose throughout his hospital stay was fairly stable. I have fasting readings at 148, 111, 107, 180, 211. So kind of varied throughout, and with those numbers he should be on a sliding scale. His urine showed no ketones, so he didn't show any signs or symptoms of DKA. His creatinine function was 1.98. His BUN was 31. Sodium 140, hemoglobin 11.4, hematocrit 34.6, troponin was initially when he arrived 13.7, increased to 95, which then increased to 1,254. Finalizing, the increased number was 3,227 upon the day we were there. His liver function was fine. It was 25 was his AST, and his ALT was 18. His GFR was 25. His platelets were 205. His bili was 0.5. White blood cell count was 7.1. So at this day of his hospital stay, so day 6, he was mainly there to monitor his kidney function because of his kidney disease stage 3. And after the dye that they did for the angiogram, they wanted to make sure that his kidneys were working functionally before sending him home. So he was very independent when he was in the hospital. He was maybe a cis times 1. Didn't really need a lot of help from me. So upon my assessment, 80-year-old male, alert and oriented times 4, presented to the ER for left-sided chest pain, arm pain, and jaw pain. Again, history of CKD, hypertension, hyperlipidemia, diabetes type 2. So he's currently on a cardiac diet with no caffeine. Patient was in sinus bradycardia per EKG. Need to fix that. The EKD. So his pulse was another reason that he was still in the hospital. His pulse went down to, he was pretty Brady all day long, but his pulse at nighttime got down to 35, so they were monitoring that as well. His pulse upon assessment was 45. S1 and S2 clear, heart auscultations, no murmurs, bilateral pulses felt in radial, pedal, and tibial extremities. He did have +3 pitted edema in his bilateral lower extremities. He had fine coarse hair on his lower extremities as well, which is suspicion for PAD. His lung sounds were clear with no crackles bilaterally. Non-labored breathing noted. Skin's warm, pink, and dry. Normal skin turgor. His last valve movement was 2-3, and valve sounds active in all 4 quadrants. His urinary output was 1,200 mLs in 10 hours with input of 0.9% normal saline at 120 mLs per hour. Denies increased thirst, urinations not increased hunger. He denies. He did eat 100% of his breakfast and lunch with snacks brought by his wife. Patient weighs 82 kilograms, height 71.5 inches. BMI is in with normal limits at 24.7. We did neurochecks Q4 hours. He had normal nerve response in upper and lower extremities post stenting. His BP was 130/79 with 97% O2 at room air. Respirations were 12, and he reported no pain. So let's look at his medications. So his medications that he was taking while hospitalized was Plavix daily for prevention of blood clots due to the patient's history of MI. He's on Zetia 10 milligrams at bedtime to stabilize patient's cholesterol levels. He's on hydrochlorothiazide to lower his blood pressure and prevent fluid retention. Insulin Lispro, 2 to 10 units per sliding scale to treat his hyperglycemia. Isosorbide, 30 milligrams daily. A vasodilator used to treat chest pain. He's taking for the history of MI. Pantoprazole used to treat and prevent acid reflux buildup in the stomach. Most, if not all, patients are taking this while hospitalized. Low-dose aspirin, aspirin 81 chewable as an anti-inflammatory used to reduce the risk of heart attack. Patient is taking for preventative as well as blood thinner. Normal saline I put on here, which we discussed already, and he has PRN dextrose 5% and 50%, as well as glucagon used to prevent hypoglycemia. So for the nursing diagnosis I use for him, risk for decreased cardiac tissue perfusion related to diabetes type 2, hypertension, hyperlipidemia, and coronary artery blockage as evidenced by his non-STEMI. Number 2, I put risk for imbalanced fluid volume related to kidney disease as evidenced by edema. And for 3, I put risk for delayed surgical recovery related to impaired healing due to circulatory changes as evidenced by diabetes mellitus. For his short-term goal, I put by 48 hours post-op, patient will have no neurodeficits and stable glucose levels. For his long-term goal, I put in 1 year, patient will not have a coronary blockage that requires stents. So interventions, patient was given insulin Lispro 2 units to lower blood sugar from 148 to 108. Monitor signs and symptoms of hypo or hyperglycemia to prevent DKA, coma, or death. 3, reposition patient Q1 hours to prevent breakdown of skin, no pressure injuries. 4, neurochecks Q4 hours to monitor blood flow to extremities, organs to monitor findings of neuropathy and loss of consciousness. For evaluation, after the review, patient's initial lab work and status compared to his current well-being, patient's considered stable. Patient's kidney function post-angiogram to now has improved. GSR from 25 to 32, creatinine 2.31 to 2.10, BUN 43 to 38. Patient's wife at bedside and is able to assist patient with continuation of daily medications to prevent further diabetic, cardiac, or kidney damage. Patient is to stay 48 hours post-angiogram to continue to monitor for any side effects of study. He will be released home with wife at hour 48. So that was my case study. I do want to add, we did an EKG, which he showed sinus bradycardia, which we discussed. His echocardiogram, his ejection fraction was 55 to 60, which isn't bad. His left atrium was dilated, as well as atrial septum thickening. His chest x-ray showed no acute radiograph abnormality, and his right groin angiogram with mid-vessel stent placement. So he was fairly a healthy diabetic. Again, I chose this patient because of his micro and macro. Let me see if I have anything else to add. Urine A1C, hyperglycemia, we discussed that. So for the micro, we discussed the neuropathy. He did not have any neuropathy, but I wanted to add that he had chronic kidney disease stage 3. His eye exam was normal upon my assessment, but he did state that he sees the eye doctor twice a year as recommended, and then his neuro assessment was normal upon my assessment, and he denied neuropathy.